Dan, this is good stuff. You should.
Oh, like the inside.
Yeah, you gotta hold it like this so they can hear you.
Check 1, 2.
That's right. Tell us more about the athletic doctors in med school.
There's lots of them. I think there's probably a strong correlation of like the type of personality and where they go to. Like
Yes.
you know, those athletes, those semi-pros, the ones that were supposed to be professional athletes, they're like high chance they're going to become orthopedic surgeons.
Okay.
You know, they want to fix things and they care about
The Cowboys.
The Cowboys, yeah.
But the athletic Cowboys.
The real Cowboys become like general surgeons.
Really?
Like the gunshot wounds, trauma wounds. The last one, yeah.
Like the ER surgeons?
Yeah, the ERs, yeah.
Okay.
The students who don't really love socializing with other students are more
Anesthetists?
pathology, anesthesiologists. Yeah. I mean,
They're like
I'm
patients,
joking around, but there's
their
definitely...
most lively patients are in the ICU.
Well, what do you think about the fertility doctors? Who do you think they are? No comment?
Well, I don't know. It depends because there's so many different types of fertility doctors.
Yeah,
Whereas
sure.
you're right. I will say I dated a cardiologist, and when I would tell people that who were also in medicine, they were like, oh, well, God, you're dating God. I was like, I don't feel like he thinks that. But he did, in fact, think he was God.
Right, okay.
And
he really was God.
yes. But then the irony was that I broke his heart.
Nice.
Oh, no.
But he could repair it.
I don't know. I ghosted him after that. Hopefully he's still alive.
He's alive.
Yeah. I don't know, actually. There's so many different types of fertility doctors. But you, which is why you're here, did you know that you're the only Canadian expert that I've brought on to the show?
Really?
Yeah.
Nice.
The rest of them are American.
And they fly down here?
No, I will like do a Zoom thing.
Oh, wow. Okay.
Yeah.
Thanks for having me.
I'm honestly so delighted that you agreed.
Same.
Yeah. But like you are a detective. Like you're very curious.
Yeah.
Like you've chastised patients before for not knowing their file well enough.
I would use different words.
Right.
But I think it's important, yeah.
Because advocacy for you, like you think it's really important that patients are able to advocate for themselves and understand what they need and what they don't need. And as opposed to just like everybody gets the same treatment, everybody gets the same protocol. There's a lot of fertility doctors that do that. And sitting sort of like as like an elf on a shelf, I can see from the perspective of an acupuncturist, like, oh, well, I have, 10 patients in this room. 5 of them are seeing this one physician, and 5 of them, very different patients, are all getting the exact same treatment. That's not like good detective work. That's kind of like copy paste.
Right. I mean,
You can defend it. I expect.
I'm going against myself here, which is rare. But
Oh, wow.
no, because the question is, are you personalizing it correctly?
Right.
You try your best, but like maybe going off script is bad, right?
Right. Elaborate on that.
Let's talk about, there's clinical and there's lab. So when we think of the embryology lab, which is where we get our eggs and our sperm and we try to make our best embryos and we biopsy and hatch it and transfer and whatnot, that traditionally the best labs in the world are like obsessed with like quality control and SOPs. And every egg and every sperm is treated the best, like almost like a factory.
Okay.
But clinically, if we do that, then, that's sort of your reaction. Why is everybody getting drug A? Why is everybody getting this dose? Why is everybody getting this protocol? And maybe it's correct. It's probably not. We do a little bit more personalization clinically. For example, if someone has a high reserve, which means lots of potential eggs, then we think, great, you're going to get lots of eggs, more opportunities, more success. But what we know for sure is you're going to get more symptoms and you're at risk of what's called OHSS, ovarian hyperstimulation syndrome. So those patients, you got to think about that. And you don't want to do what's called a fresh transfer, because if you do get pregnant, you're going to be extremely sick and the pregnancy rates aren't as good. So if, for example, your protocol is fresh transfer for everyone, and then you applied it to someone with a high reserve, you're doing them a disservice. So like matching, we do it a little, we all do some personalization. The question is like, what level of personalization?
I have a few patients that see you. They don't have the same protocols at all. So I think you're turning that dial quite a bit.
Okay.
Like, for example, one question I'm always curious to get an RE's opinion on, because when I have searched it, like anecdotally, I have seen adding certain adjuncts like saizen, for example, have very good outcomes. Now, I have a very small sample size, but when I'm trying to search it online, I can't find anything definitively to give to patients to say, here, this is the reason why you should ask about this. I wish that I could, because then I would have more patients that would be able to have that resource available to them, and maybe they'd be able to advocate more for it.
Yeah.
Like, what's your opinion on?
I think that's a good example. Like saizen, which is a type of growth hormones, there are others. That is it useful? If so, for everybody or for some people, is it worth the benefit? For example, if it's an extra few $1,000s, and for that patient, that's a matter of trying again or not trying again. Is that your best use of your resources? We always try to use the literature. We can't do studies on everybody all the time. So we go to the literature first. And even the literature, we'll come out of that room and we don't all agree on what we just read because, but I think, yeah, it depends on the patient. And one of the key things that I think you'll agree with me is like, you need to walk into the next cycle with hope and optimism, not fake hope, not false optimism. So I'm always going through the statistical chances with someone. I have found that people, if you listen and personalize with the intent to help, they're just more optimistic walking into it with like the reality.
Right.
I'll give you a good example. I think you can hold on to. Like in Ontario, there is government funded IVF cycle, but it's one cycle and it doesn't cover everything, but it covers a lot. The generation of embryos, embryo transfers, but not medications, not PGTA testing if you choose to do it, but it helps a lot. Okay. It's very clear. And most IVF cycles, depending on your situation, could be very low chance of success or pretty good chance of success, depends your situation. But it's very clear if someone were to not want to wait and do funded IVF and paid for, we call it a private cycle, and doesn't succeed, and then you offer them the opportunity to do a funded cycle, your name has come up, I'd say 80 to 90% of the patients say, let's try it again. This one's covered by the government. I'm ready to go. If you have someone who's tried a government funded cycle and fails that cycle, very much lower chance that they're going to try again and pay for it. And you say like, why? Overall, it's the same amount of money. It's the psychological,
Yeah.
like how you went into that second cycle.
Yes.
Why would I just pay for something that just didn't work?
Right.
Versus like, why wouldn't I try something that's free?
When I'm coming back to like certain adjuncts that you think would aid somebody's chances in having greater success, what would you say the most benefit in terms of like a general like adjunct?
That is a tough question. So I'll tell you my background. My background is mathematics. So my mind works
As a ratio.
very logic,
Yeah.
numbers based. So
You're a percents man.
I'm a percent fan. So this is what I think we can all agree on. Fertility drugs, gonadotropins, they're probably equivalent. Like drug A, drug B, drug C. There isn't one, you can find studies, but there's not one that clearly dominates the others.
Right.
There's people who will disagree. That's fine. We need the fertility drugs to stimulate more follicles because more eggs gives us more chances of success. So this is pretty clear.
Yes.
So we want drugs, we want more eggs, but we want to do it in a safer way. Now, where we all differ is like, what's the dose, when to trigger, how to trigger, and these sort of add-ons. Sometimes we add like forms of testosterone or growth hormones or anti-estrogens. If you went back to my medical charts over the year, you could sort of see trends like, 2022 was the year of letrozole and 2023 was the year of growth hormone. Right. And sometimes it's because new studies come out and you fall in love with it or you want to change it up.
Right.
But I've been using a lot of personally like testosterone priming for sort of the lower ovarian reserve because I do believe it makes those follicles more sensitive to the stimulation medications, and these low reserve patients, any extra egg you can get is going to help you. So what's your favorite add-on?
Saizen.
Saizen, okay.
That's a good one. I love it.
Yeah.
I wasn't sold initially, and I do wish I could find more literature. You're seeing A Beautiful Mind?
Yes.
You know how he has that creepy shed
Yeah.
and he has the, like, strings and the, like, murder mystery scene on the wall.
Okay, where is this going?
This is what my bedroom looks like, but with patients.
Oh,
So, like, there's certain patterns that I'll recognize and notice, and that was one of the patterns is I would have patients with their second retrieval after not having done it for their first would have the number of euploids compared to their first retrieval was so significant once they added this
gotcha.
medication, which is I understand like a dangerous thing to say on a podcast that maybe that shared amongst people and then they think it's a miracle, but it is a shocking number of people who did have poor success and then had much better success. So much so that it's hard for me to now, when doctors say, well, there's no difference, oh, it won't make a difference, to not be like, I don't know, like, how could, if a sample size of like 50 people, for example, and 49 out of 50 had success, that's significant, I think, even though it's a small sample.
Yeah, I'll push back a bit because,
I'm
like,
ready.
from a statistics point of view, it's how you do the study, right?
Right.
So,
Fair.
if you take 50 people who strike out and you let them go on bat again and you change their bat from
Yes.
blue to pink,
Yes.
some of them are gonna hit a home run the next time,
Fair.
regardless of the bat.
Yes.
So there's a little bit of that. But I'll tell you how we fertility doctors think about saizen.
Okay.
Some of us think makes no difference, costs money, it's more injections, stop.
Right.
Some of us think it's great. You should use it for every single cycle. Some of us think, you know what, maybe only for the low reserve patients.
Right.
And some of us think, well, maybe it's actually for the young patient got tons of eggs and you see a huge drop off to blastocysts.
Right.
Yeah. And some of us think maybe we should figure out if somebody is growth hormone deficient before we give them growth hormones. So
Yes.
some of us will do a blood test for IGF-2, which is sort of a marker,
Okay.
and only give those patients extra growth hormone.
Do you do that?
I don't. I do it more clinically as opposed to biomarker.
What patient would you opt to give saizen to out of the
So
categories that you just gave?
if you put the spectrum of fertility doctors, I'm always playing it safe. I'm not the extreme. So like I'm
Right.
not give it to everybody. I tend to not give it in the first cycle because who's to say you need it?
Right.
But I definitely, it's something I always consider for a second cycle. I usually either give it to a high responder with a very low blast rate,
Right.
or sometimes to the low reserve patients. But I'm humble. If it works, I'll celebrate with the patient. But I really don't know what specifically
Yeah, what
we
was
did.
that?
Yeah, I don't know what the magic was.
Yeah, it's always funny because if you have multiple retrievals, I'm always surprised when you'll have one round that's trash.
Right.
And then the next round, not that much has changed. And it's significantly better from the standpoint of like the maturation of the egg.
Mhm.
Like, what would you say is the appropriate timeline? Like, do you believe in multiple retrievals over a short period of time? Or do you think that there's more benefit to waiting, like doing, an every 90-day scenario?
Okay, well, the whole concept of 90 days is the idea of like our sperm and our eggs sort of, well, our eggs don't really regenerate, but the growth from the primordial. So the whole 90 days to me, I was like, when patients ask about it, I say, I'm all for the 90 days if we're going to make something significant change. So
Right.
if you tell me that in 90 days you're going to be the same as you are, you're probably just wasted 90 days.
Right.
But if you tell me that your diabetes is now going to be controlled and you had significant weight loss and your anxiety is now under control and finally you're eating well, yeah, let's wait 90 days. But I always tell the patients, like, you tell me, I know you for 30 minutes. You tell me how motivated you feel.
Right.
Otherwise, we're wasting time.
You're Dan with a plan.
Dan with a plan. I like that.
I like the fact that you're actually looking at that as like a whole picture. Do you do that with the male patient as well?
Yeah.
What sort of changes are most significant, do you think,
Well, again,
to make better sperm?
I start with the extremes. So
Yes.
like if someone is morbidly obese or severely underweight, that's probably not a great thing, right? So
Right.
go this way or go that way. if you're a smoker, daily cannabis user, daily intoxication, there's no good that's going to come off that.
Do you have patients who are daily intoxicated? Yeah,
I mean,
intoxicated on the
what they
daily?
tell me and what happens is you never really know.
I'm always surprised that these people are still alive. I think I could manage maybe a week of that and I'd be
Well,
dead.
they're in their 30s and 40s when they see us.
Like, I'm a youth.
Yeah,
Just,
you're part of it.
I don't think I could manage. I couldn't manage that when I was a teenager.
I'm talking about like the extreme cases, right? But like still the
Right.
binge drinking is like alcohol poisoning, right?
Yes. Wow. Okay.
So I always look for the extremes. Do you have diagnosed diabetes? Is your thyroid under control? What can we optimize? And that's it. I mean, there's a lot of stuff that's just what I see. I always talk about macro and micro. Like macro is like, I can see it. It's on a picture. There's a number. Micro is like, I have no idea. Like
Right.
it's your gene, it's your receptor, it's an enzyme, it's micronutrients. I don't know. I can't see it. Like,
Yeah. Once we've controlled what we can control from like a bigger picture, from a male perspective, they've agreed they're going to lose weight. They are going to quit smoking. They're going to stop using cannabis. They're going to maintain more normal drinking habits, a drink a night kind of idea. Maybe even less than that, because they did change that, was in terms of like what was acceptable.
Mhm.
It's interesting because I looked up out of curiosity what the level of alcohol was that is damaging to sperm. Because you know me, I like to be the hard hand, and I couldn't find anything that was even remotely acceptable. It was like binge drinking
Right.
is what damages sperm. Just like 5 drinks in 2 hours.
Right.
So if you're doing less than that, it's like,
Well, again, that's the measurable stuff.
right.
But to me, I always tell patients, nothing is binary. Like a sperm count of this doesn't mean you can't get pregnant. And a sperm count of this means I can't believe you're not pregnant yet.
Yes.
But, so if 5 drinks a day is really bad, probably 0 is the best. And that's probably a spectrum.
So after you make those tweaks, what would your, like, if you're nitpicking
Well,
and
to
asking
be
them,
fair, I recommend those tweaks. Like whether it
Yeah.
gets done is what we rely on
Fair.
experts like you guys to help.
I have the professional babysitter.
Yeah.
I'm the professional nag. But you know what? The husbands they're so nice. They come in afterwards once the baby has been born, and they're very appreciative for my nagging. One of these poor guys I was texting, I was like, "Did you exercise today?"
Afterwards?
No, during.
Nice.
I was like, "Check mark if you did. Sad face if you didn't." He was like, "How did you get this number?"
Accountability. It's good.
I was like, "Your wife gave it to me." He was like, "She was tired of nagging you, and I have an endless desire to nag people." 6 children.
Yeah.
The like eldest one has like left pretty much now. She's 13, but she doesn't let me nag her anymore. Like it's like she doesn't hear me.
Or she doesn't need it.
No, she needs it.
Okay.
Yeah. she's in desperate need of nagging, but fine, she's going to find someone who can do that for her. I'm not it anymore. So how would you move the needle in terms of creating more integrative care?
So I think most fertility clinics have a naturopathic program associated. I'm not sure they're always connected through an EMR. I think that's step one. But I think some of us, you can appreciate there's different types of naturopaths out there, right? There's fertility focus. There's ones that are presenting at conferences doing research or super academic, and there's ones that are less.
Right.
So, I mean, I think it depends where you go.
You mean you're not putting a castor oil pack on yourself on a regular basis to break down scar tissue?
I would if I knew that it helped. I don't have any scars. Yeah.
Well, I'm covered in them and they have not worked for me. I'm going to tell you that. Yeah, that's interesting. I haven't ever had anybody turn it back to that. You're right. I
regularly. You circle like.
Yeah, I regularly.
You don't get the feedback, right? Like, for example, I didn't know you were so in love with saizen.
Yeah, I love it.
Right, and that's news to me. And
well, how do you feel about that?
I think I'll pay more attention to it now.
Yeah. Sure. Wow. Thank you. Yeah. See, look at this. Yeah.
All about feedback.
Yeah. No, I feel like it's important to have an understanding of the headspace of the person that you're working with from an integrative model. But a lot of, you're right, practitioners on both ends of the spectrum, from both like the Chinese medicine, naturopathic world, but also from the fertility doctor world, both only think one way is the right way. In like a good example, for example, I've had patients that have come to me who have been seeing, a more holistic practitioner for a number of years while also trying, and they have yet to had a workup done. Like they haven't had a sono, they haven't had an ultrasound
Because they refuse, or it wasn't
because
recommended, or they didn't know.
it wasn't recommended. The idea that the human body, when in balance, can conceive without intervention, to which, my response is like, my human body had a giant dermoid cyst that tried to kill me when I was 18.
Oh, okay.
So if nature had been let to run its course, it eventually would have caused sufficient damage and I would have potentially perished. Is that a good way to let nature run its course? And to which the patient is at that point like stunned and looking at me like, help, how can I get out of here? This is not the sort of practitioner I thought you were. But I always recommend that people get a workup done, like before they do.
Otherwise, you don't even know.
You have no idea what you're working with.
Yeah.
But at the same time, so, either pushing against any type of allopathic medicine and then pushing against any type of more holistic medicine, neither is going to
Stay in the middle.
be a good outcome. How can a more researched integrative practitioner, like a holistic practitioner, work better with doctors that are stubborn? Like, what would your, even from a patient standpoint,
But
like how
what do you mean by stubborn? Like, give me, like, what is it that
like
you sometimes see resistance?
they don't believe in any lifestyle changes making an impact, because it's hard for a patient to switch fertility doctors.
Yeah, it takes time and
Takes
effort.
time, effort. They don't want to retest. They don't want to start again. But they, at the same time,
But let me break that down though. So even if they didn't think that, they wouldn't be promoting a suboptimal lifestyle. They wouldn't say go smoke and don't eat
No.
well, but they're just saying, are they saying
say nothing you can do will change the outcome.
well, one, I would say you don't need your fertility doctor's like approval outside of the fertility clinic. I'm not saying you should include them. To me is like if something doesn't hurt, but hurt can be false hope, time, money, and stuff like that. If something doesn't hurt, it's fine with me. As long as you understand what you're walking into.
I think what happens a lot is in partnerships, the one partner might be on board. She wants to make changes. She's already doing what she needs to do from a lifestyle standpoint. But in order to bring her husband on board, she needs the okay from the doctor, or for the doctor to promote, making changes.
Yeah, but I think that's about really speaking to your patient. So sometimes I have patients that say like, I can't get my partner to come in and do a repeat test. And I was like, why? Explain to me the why part. Is it because he lives so far away? Is he embarrassed? So like the more you tell me, the more I can help you. Okay, well, maybe he can collect at home and bring it in. Is it he's worried about the results? Okay, well, maybe I can review the results with him and not with you in front of him. Like what part, like just tell me what the issue is and then I can help you.
So if I had a qualm, for example, with a patient's husband smoking excess amounts of cannabis,
Yep.
how can I change his mind
Oh my God.
if
I'm the
his
wrong person
fertility
to ask.
doctor says it does not matter?
If his fertility doctor says cannabis doesn't matter.
Yes.
And his sperm sample's great.
No, poor motility.
Well, then what does like you want to change whatever you can.
Right.
You're saying he doesn't think that's a variable. I would say, well, we know the end product isn't great. You can't change your age. You can't change your genetics. Let's think of variables maybe we can change. Oh, daily cannabis might be one of them.
Right.
Why don't we have our own experiment? Why don't you stop for 3 months, pick a different vice for a while, and let's see.
Right.
And maybe for you it does make a difference.
Options.
Options, yeah.
I like that.
Yeah, you got to work with the patient.
Dr. Dan, This is something I was mulling on before we popped on. I think I like alluded to it in our pre-show chat, because this is who I am now. I have a pre-show.
No big deal.
No problem.
Treat me the same.
That's right. I'm just a regular person, guys. I'm just a regular person. What do you do now, like differently, as a fertility doctor who's been in the game for a while, than compared to at the beginning?
Yeah, it's a great question. I think, like, if you saw my notes and the way I speak to patients, I think it's evolved over the years. I think one of the most important skills I've learned or working on is like reading the room. Who do I think is sitting in front of me? What's their goals? And I always ask them. And how do they like information? Like, I have my style, but sometimes I have to change it. Like, some people, less is more. I want you to take this medication and call me tomorrow, right? And some people want me to go through all the abstracts that I've seen in the latest conference and let's discuss them all in micro details. So, like, you really need to understand. I think I've developed, sounds wrong, but we call it defensive medicine. Defensive medicine is like, because I can't control the future, there's nothing I can do to guarantee you're going to succeed. I'm just trying to optimize it. Okay. I need to justify, I always want to be able to justify to you why I did what I did. Why did I pick this dose? Why did I trigger you on this date? Why did I say that instead of this? Because first of all, it makes me accountable. I'm thinking, like, this is why I'm doing it. And if you followed my logic, you would have made the same decision. So you can't be upset with the outcome. You should just appreciate the fact that we try to optimize. So that's kind of like my most updated way of doing it.
Your communication.
Communication. So, for example, if someone's going through an embryo transfer and their lining is 6.8 millimeters,
Okay.
and I know in my mind that patient is fixated on the number 7. Somebody gave them a number 7. I assume they think under 7 not pregnant, and over 7 I can't believe you're not pregnant. And if I were to say let's start progesterone, go for the embryo transfer, and I succeeded, then I'm a genius, right? But if I don't, it's why would you ever transfer? So I am putting myself in the patient's shoes and say, I think that's what she's thinking.
Mm-hmm.
So that's a patient where I pause and I sort of say, let's look at your images together. It's not like measuring a ruler on a table where we're all going to get the same number. There's like subjectivity to it. It's not so simple. Okay. Look at the pattern. Look what you did in the past. Look at our data, 6.8, 7.2. You're in the same category. I've thought about it. I know it's 6.8. You have my reassurance to go forward. And even though the same decision was made go forward, it's a very different patient experience.
Yeah. They're involved.
They're involved and they understand why.
Great.
Yeah. So that's like the evolution of the way I've been counseling.
How did you used to? Would you just be like, look, this is the way it is. Take this pill, call me in the morning.
It's a thing that you only learn by feedback. You learn by that the patient who's not pregnant and had a 6.8 who comes back so upset. And I was like, how come I'm sorry it didn't work, but you seem very upset. They're like, why did you transfer me? A nurse told me that it was under 7 and you still, and I was like, oh, I understand. You're putting a lot of emphasis on, so it's about getting the feedback.
Right. And taking it and changing your approach.
Yeah. Thinking like, why does they think that way? Why do they think that way? What is the patient thinking is what I'm always thinking.
You are the patient.
It's the only way. I don't know how to practice otherwise.
Why did you choose fertility?
Oh, a few reasons. So, my background is math. So the world only makes sense to me in like logic. Like, I like puzzles, but logic puzzles don't, I don't do so well at an art gallery. I don't get it. So to me, whenever I was in medicine, I didn't like the subjective stuff. I like the objective stuff. Like depression fascinated me. Stomachache fascinated me, but I can't measure it. I need like, show me your hormones. Let me see this tumor, whatever. I needed objective stuff. So that's number one. I really like to complete tasks. Like I get like a high off of it. So like to me, every case not only was a puzzle, but there's like an end to the puzzle. Like, when you finish the puzzle, like it succeeded. And really, I loved that it was such a new field. I mean, I've been practicing just over 10 years, but you make these decisions even earlier, like the first IVF baby, which changed, you can imagine we didn't have much before that. Was like, she's only like 45 or so years old, just over. So to me, it's like, it's a brand new field. And I want to be part of, I want to be part of something that's just going to change like crazy. And that's what I did. Yeah. I was just betting on a booming field.
Did you have like a particular passion for women's health? Because it's interesting because even though fertility technically is both sides, I bet you mostly deal with women
I'd say that's
in
the
your
majority.
day-to-day
Yeah.
experience. Um, like, have you found that like certain things over the last 10 years, like Femtech, for example, or like home testing, or all of these different ways to use numbers from a patient experience, like how it has it changed your practice?
Yeah, I mean, I love Femtech because I just see so much opportunity. Like I always say at my clinic, like one result could be random, but if a patient's complaining about two different patients complaining about the same thing, that looks like a pattern to me. And let's stop and think of like what's the issue, right? So when I see like the fertility space and how it's evolving, there's so many opportunities. Like well, good examples are someone who has irregular cycles and wanting to conceive and, struggling for 3 years and coming to see me. And to me, I sit in front of them and I listen to their story. In my mind, it's like, wow, you have irregular, like wildly irregular cycles. You're probably not ovulating. From my point of view, biologically, you've not even started to try. You're not even ovulating, but you have been like struggling and suffering for 3 years. So what a huge disconnect. Like you're suffering for 3 years, and in my mind, you haven't even started. It's not even day one yet. And it's like because she didn't know. She
Yeah.
didn't know that irregular cycles are not normal. She didn't know you had to ovulate. She didn't know 3 years is a long time. I mean, I'm just making up an example,
No, and
but
it's a good one.
yeah, the other one is like male sperm testing. Like, you literally can't not know your semen analysis unless you look under the microscope. So, a good example is someone who's had a vasectomy. The vas deferens is cut. Testicles are working, testosterone's being made, sperm's being produced, strong erections, normal sex life. You ejaculate, but there's no sperm in the ejaculate, right? And so men don't know until they come in. So it is fair to say wait a year if you're under 35, but I always say wait a year if you're under 35, asterisk, if there's no red flags.
Right.
So if you are unable to have sex because you have significant erectile dysfunction, why are you waiting a year? If you're a single woman who needs donor sperm, don't wait. Well, you don't have an option at home. Come on in. So for example, for men, if you had a way to test at home, you can at least find the outliers, people who have no sperm or extreme sperm, who probably save themselves a year of heartache.
Yes.
Those are just examples.
A frustration that I have on a regular basis is that men aren't able to get semen analysis until they're in a fertility clinic. Like I was sort of under the impression that they could go to their GP and ask for a semen analysis rec, but then not all life labs are doing them. So it makes it pretty tricky because fertility clinics all have such a wait list that they don't think, like if you provide any friction, I found especially when trying to like kind of funny when you're trying to create a semen analysis, friction is normally important. But in this case, any friction is no good and they won't do it. And so I don't like how do we create a better path, whether hypothetically or in actual reality, for men to have more regular semen analysis?
Well, I'll add one more layer. It's not just a test because the tests mean nothing unless you interpret the test,
Yep.
right?
Yes.
So you also need like
Fair, like a GP
either
that would understand
either
how to
someone
interpret it.
or a website that like walks you through it and say you have no sperm.
Yes.
No sperm is not compatible with natural pregnancy. Go see someone.
Yes.
Or you have irregular cycles. You very likely don't ovulate or irregularly ovulate. You should not waste time.
How would those like, how can we improve on that? Do you have a website or a
Yeah, I mean,
like
Bird and Bee
resources?
is a company that I advise, and they do both supplements and they do at home testing. So that, again, the concept here is quick, accessible, cheap, and looking for extreme outliers.
Right.
Do you ovulate? Is your FSH through the roof? Are you going through early menopause? Do you have no sperm? So, and the education piece, because like what you think is not you, but what we take for granted is that not everybody knows what we think is basic information. We always joke that we learn how to not get pregnant, how to not get an STI, but there's never a second version of sex ed in university of like, did you know that?
Yes.
Yeah.
Yeah, it's funny you used the example of somebody who had been trying with wildly irregular cycles. Like 5 years ago, I had a patient come in who had not had a period because of very stubborn PCOS for 2 years at that point, and she was also trying. And so when she came in, she said, "I've been trying for 2 years. I can't believe I'm not pregnant." And then I'm going through the intake. "Well, when was your last cycle?" She, "Well, I haven't had one in 2 years."
Right.
And my eyes almost like,
But we see that all the time.
"That's wild to me." Yeah. So
But a lot of it is education. But I mean, I think all of us are working on the stigma part. I think it's getting better over the years. But like,
yes.
no one wants to go to a fertility clinic generally, right? So it does take a lot of effort to be like, okay, we're doing this, we're jumping in.
Right.
So I don't blame them, but like, they're at least be educated and then make a decision.
Really, I'm glad that you brought up Burden B because I'm a big fan of the fact that you can test your FSH because I feel like that's not the focus on in most fertility clinics when you go. The focus is almost entirely AMH, and that's sort of where you stop. I actually got frustrated because one of the clinics that is doing like fertility checks for women only included AMH and an antral follicle count, which I can appreciate from like ease, but it doesn't give a very full picture of what is going on with your fertility from the standpoint, unless you're wanting to like know whether you should freeze your eggs or not, for instance, and like what, how much stim you're going to require. But, like, to not include FSH is just so
Okay.
frustrating.
So I need a few minutes to sort of let you know how I think about that. So first of
Yeah.
all, there's this concept we call ovarian reserve.
Yes.
So the idea of ovarian reserve is a quantity test. So that's like
Yes.
the number one myth that doctors and nurses and patients get wrong. Like
Right.
age is the best predictor for egg quality. Not everyone acts the same as their age, but on average. And reserve is a measure of egg quantity. Okay. Ovarian reserve essentially is multiple tests that we put together to sort of say, this is where we think you are. It's a bit of an estimate. It could be blood tests like FSH and AMH and ultrasounds like follicle count, and sometimes there's additional ones. Some fertility clinics do all of them, get more data. Some will just do an AMH, some will just do a follicle count, and so forth. What we know is that everybody, it doesn't matter how fertile they are, eventually will struggle. Eventually will have miscarriages. If I've not met someone who's not gone through menopause eventually, right? And over time, the quality and the quantity. So everyone's ovarian reserve goes down.
Yes.
Now, not always the same trajectory, not always starting at the same point, but everyone. So to me, having a high FSH is probably one of the last markers of ovarian reserve. So for example, when we're in menopause, which means our brains are sending signals to our ovaries, but our ovaries they just don't listen. It's like ovarian failure, essentially, or ovarian resistance. We're shouting at the ovaries. Ovaries don't care.
I equate it to like a badly behaved child.
They don't listen at
They're
all.
bad.
So they don't make eggs, then they don't make hormones. And therefore, with the negative feedback, our FSH is just screaming. Okay. So if you take someone menopause, FSH is through the roof. In fact, one of the coolest stories of fertility, I don't know if you know this, is like the original gonadotropins, the original fertility drugs. You do know this. Nice. It came from urine.
Menopausal women.
From a menopausal woman. Menopausal urine, right? Because FSH was high and you would filter it, and now you've got FSH that you can give to someone whose ovaries will react to it.
Yes. Now we have all these people who are going to go and ask their moms for
their urine.
They're going to distill their own, make their own fertility drugs.
So there's liability in what I'm saying.
Yeah. Nope.
But the point is that FSH will eventually creep up, and it's telling you that your ovarian reserve is really low. So the reason Bird and Bee is doing the urine FSH is it's the same principle: low cost, accessible, and look for outliers. So the most important part is the education around it. So high FSH doesn't mean you have bad eggs, doesn't mean you can't conceive naturally. It's not a measure of egg quality, but it is a screening test. You are at risk for having very low reserve. I would go get more information. Now go to the clinic, get the blood work, get the ultrasound, and find out, and then have a chat with your doctor. The reverse, just because the FSH isn't high, doesn't mean your ovarian reserve could still be on the lower end. It just hasn't reached the very low end.
Right.
Yeah. So again, it's the extreme. The sperm example is you're looking for no sperm or very low sperm. Yes. Just because your sperm's normal doesn't mean you're going to get pregnant.
Because you're a reasonable and percenty man, you're going to answer this in the same way that like my parents used to answer my questions when I wanted them to give me a really
upset at my answer.
I wanted them to give me like an extreme answer, and they would say something just I was like, that's the same as where I was before I even asked the question.
Okay.
So I'm like,
I'll change it up on you.
I feel like now you're going to be really extreme now that I've prefaced it with this.
I'm going the other way.
Okay,
now.
great.
I'm going to surprise you.
But which would you rather?
Yeah.
I feel like you would be hard to play this game with because you would give like a really detailed, rational answer.
And you're not looking for that.
I'm looking for something outrageous.
You're looking passionate.
We'll do it. I want like National Enquirer outrageous. Okay. Which would you rather see a patient with? High FSH or low AMH? Which one is to you more frightening, not concerning the other two variables? Well, like we're talking like over 50. Over 50 and under 5. Under 5 AMH, over 50 FSH.
What's more concerning?
Yeah, who are we more concerned about?
Over 50 FSH.
My God, I'm so glad you just said that outrageously. I thought you were going to be like looking at this from two sides of the coin. Well, I want to give you.
I just told you the final version. AMH under 5 is still some function.
Yes.
FSH above 50, that's menopausal range. Those ovaries may not respond to anything.
I'm thrilled that
that's the right answer?
Well, there was no right answer because the right answer was your answer.
Okay, nice.
But I just wanted you to be like, this.
Okay, boom.
But like, I regularly have women coming in here on the verge of like complete collapse with their 12 AMHs telling me that they're on the verge of perimenopause at the age of 33. I'm like, that's a reasonable AMH. You're not on the verge of perimenopause.
And more complicated is you don't know the slope of decline.
But I mean, if I'm looking at their FSH is like 5 and their AMH is 12 and they're trying to conceive, are we at this point going to be like, you need to get IVF yesterday?
Well, I'm going to open another Pandora's box.
You're going to double side the coin to me, aren't you?
Triple sign it. Okay, so that one other thing that I've started to change over the years is I used to, the mission was like, you're struggling, you want to have a baby, I want you to have a baby, let's try to have a baby. But now I've paused and taken a step back and I sort of said, tell me about your family. Because now I've been in this field for at least 10 years.
Fair.
And then I see patients coming back after success, which is great. And then really struggling. And I was like, oh, I wish that we really, I wasn't thinking 2 steps ahead.
You weren't family planning.
I wasn't family planning because like even having a baby is far from a guarantee here. Right? So I wasn't like going for 2 before I can have 1.
Yes.
I was just going logic on it. But now I zoom back and say like, tell me about your family plans. We may not get there, but what, if you could do it, what would it look like? And maybe we have to take it, maybe we got a plan for the future here. So sometimes in those scenarios, Not saying they can't get pregnant without IVF, but maybe this is a good opportunity to make some embryos for the future. Best case scenario, you don't need them. You already finished your family. Worst case scenario, you didn't have them or it didn't work.
So from like a practical, logical standpoint, that's when you would recommend that patient, but you wouldn't like tell
Wouldn't tell
them
her, no,
to
remember
like
that's the
run because you're a reasonable person. You're right in your middle of the road. You'd be like, walk and discuss with me
jog,
your
skip.
family plan.
Yes, family plan. But that's just one part. Why is she not getting pregnant though? She's 36, has regular cycles. What else is going on?
A lot of the time, I have people that are coming just preemptively. Like, they're very nervous, but they've gone and they've done one of these, antral follicle count, AMH test that's come back that this is the result. And then they get the full workup, which then to me, I'm like, well, this isn't an emergency.
I think the biggest pushback we get from the field, forget fertility, like if you were to do blood work with your family doctor,
Yes.
before you'd have to schedule a follow-up and say like, what's my hemoglobin? And be like, normal. I'm like, great. Thanks.
Yeah.
Now you can look at your results online and you're like, I don't need to go see my family doctor.
Yes.
But what happens is like, there's 55 different things they checked and 2 of them are a bit to the left. And you're like, oh my God.
I'm dying.
Yeah, I'm definitely going to die. Something is wrong.
Leukemia for sure.
Yeah. And I need to speak to my family doctor, emergency tomorrow. So some of us like that you have extra information, but we think without counseling, it's dangerous.
Yes,
AMH,
agreed.
FSH, follicle count. That's the knock. Like not everybody knows what you are. They don't have the counseling associated with it.
Right.
Yeah.
So
what are the ways you've changed over the last 10 years?
Oh my God, I love that you flipped this over here.
I'm curious.
I think when I first got my doctorate of Chinese medicine, I was in Vancouver. Interestingly, like Vancouver and Toronto from like a purely like climate standpoint, you have a very different population, not only in like mentality, but also in like physicality. Like the same things that plague Torontonians do not necessarily plague Vancouverites. Like a good example of that would be like dermatology alone. Like you're going to have a lot more people experiencing burns here and like issues with dryness. Whereas in Vancouver, like eczema, as an example, this is a gross eczema or example, but like this is a gross eczema example. But a lot of patients in Vancouver would have like wet eczema, which I had never seen before coming from Toronto.
Okay.
Whereas in Toronto, I've never seen it in the last 10 years. Again, with these like weird bubbles.
Send the Vancouver patients to Toronto.
Nope, that's not it. But I mean, you could send me there. I'd be thrilled.
Okay.
But there's also like no traffic, interestingly, which is something that's plaguing me on a daily basis here. Autopsies weren't done in ancient China. So they didn't necessarily understand what had gone wrong in the body. So a lot of it was just guessing along with philosophy. So like the concept, for example, of the spleen being a digestive organ was a best guess. So in Chinese medicine, the spleen is thought to contribute to your digestive function from an energetic standpoint. And the idea is you don't want to make it too hard on the spleen. The spleen loves routine. So you don't want to be eating at like odd hours. For example, you don't want to be having food that is too cold or too spicy or too greasy, etc. and so forth. Coming from having a degree in biology, that didn't sit with me, but it still was the only part of the schooling that I had from a diet therapy standpoint as a Chinese medicine practitioner. So the recommendation in most cases is that people not eat fresh vegetables. Don't have frozen food. You cook most of your food. You cook most of your vegetables. You avoid like smoothies and ice, for example. Same idea of like you don't want to be too cold, so there's no cold plunging. You want to keep warm, especially in fertility. Everybody should be warm. I would say that to patients back when I was in Vancouver. I would say, oh, well, according to traditional Chinese medicine, it would be advised that you have more soups and stews and rice and oats, and we're going to avoid your polar bear dips, and we're going to avoid extreme amounts of exercise. And I've hopefully evolved into a practitioner that I've leaned more into the biology side of my schooling, which I ignored initially because I didn't want to be disrespectful to the modality that I had just spent 5 years learning. So now I use evidence. So it's like, for example, a good example, patients who have high cytokines, like Markham Fertility does a lot of immune testing. And so I have a lot of patients that are being referred here to see me who have really high levels that aren't responding to prednisone, for example. And this is a really long answer. I'm sorry. But cytokines do respond really well to high intensity interval training. And there's some really cool research that's coming out about how you can really incorporate like high intensity exercise to reduce that as a concern. That would never have flown with traditional Chinese medicine.
Traditional Chinese medicine plus HIIT.
It's the opposite, Like traditional Chinese medicine, I'll get a lot of people coming to me from other practitioners, and it's been recommended that they relax, do low intensity to no intensity exercise. And I'm of the opinion, well, what are we treating? Like that totally depends on why you're here. Like if you have PCOS, then, high intensity interval training might be a good idea. If you have hypothalamic amenorrhea, maybe not. So just utilizing, testing and research as opposed to just blanket, using the diagnostics that were available, 1,000 years ago. And I'm appreciative for like seeing somebody's tongue and being able to guess what their, mainstay of their diet is a cool party trick. But it's not necessarily going to be as effective at telling me, what's going on with their insulin levels when I could have them go and get a blood draw.
Modernizing Chinese.
I'm trying to, yeah. So that's the difference. I don't feel
Do you get
pressured.
pushback from the purists?
Yeah, a lot.
Yeah?
Yeah, a lot. When my associates first started working here, one of them specifically was stunned that I let patients, have their phones while they were getting acupuncture. Like I use these press tacks so that you can still use your hands while you're here, and I use them similarly on the abdomen. So you're not lying there. Like I don't feel the need to have patients like meditate on their life in order to have success with their acupuncture. And so she didn't think it would work. She like point blank told me like this isn't gonna work the same. Like you're not gonna have the same results. Yeah, just stick it out. And there's certain things that we can do, like bring on a period, for example, using acupuncture. It's the same as like when you're trying to help somebody like induce labor, the same points. If you're using these little tacks and they're on their phone and they're drinking a coffee and they're still getting the same results as the person across the room who's lying there, hasn't had a drop of caffeine in like 30 days and does mindfulness in the morning, like it doesn't. I mean, I'm sure they have higher anxiety, but they're both still getting their period. So
You're tailoring it.
I'm tailoring it. I'm cool. I'm a cool acupuncturist, Dan.
Cool.
Yeah. Anyway, thank you so much for popping by.
Yeah, thanks for having me.
It's been I haven't gotten you to stand up yet.
I'm not gonna.
You're not going to.
And then what?
I don't know. People should know
that
you're
tall?
really tall.
I'm not that tall.
I tell everybody who's coming to see you, I'm like, just be advised. He's shockingly tall.
All right, nice.
And now that's why anyone who's come to see you is
strong.
like, and I haven't had that, but I will. I will.
I'm not that strong.
I'll be like, he's shockingly tall and strong.
But not flexible.
Well, I don't know.
Right.
Should I add that?
No, I'm not that flexible.
Okay, I'll add that. I'll be, but that's not like immediate.
Right.
Unless they test you and they're like asking us.
I'd appreciate if they liked me for my brain as opposed to
your height.
I'm okay with both.
Yeah, well.
Thanks for having me.
Oh my God, it's been a dream.
Yeah, it's really fun.
You're really not going to stand.
Oh, okay.
Oh wow! Can he be seen?
The camera has to zoom out.
You got to zoom out. Just for reference, look how small I am comparatively. Hey!